This conference will now be recorded.
So welcome everybody to the June the 15th high risk recurrent advanced prostate cancer virtual group, video chat, whatever you like to call it. We've got a big crew today already. We're starting a little earlier. I'm going to do a quick roll call. These are the people that I see on the call. Jake, Rex, Nazir, John, Nick, Sylvester, Joe Blanchette, Dennis, Jerry, Scott, Les, Russ, Len, Paul, David, Peter, and Al. Did I miss anybody? Okay. So, Nick, I think this might be the first time you're with us. Is that correct?
Yes, this is the first time.
Okay. So, first of all, welcome. That's the most important thing. We're a friendly group with quite a lot of knowledge. And I'm very pleased to, I'm not so pleased that you need to be with us, but I'm very pleased to have you and hopefully we can help you. We usually ask men who have not been with us before to kick us off, if that's okay by you. And we will we'll give you the floor for about 20 minutes to half an hour to talk about your situation. You know, what we'd like to know is a little bit about your disease background, how old you are, where you're being treated, and if you've got any specific questions. And then we will try and answer them and go from there. So why don't you take it away?
Okay, great. Thank you very much. I appreciate it. So I live on the Massachusetts-New Hampshire border, and I am 62 years old, and I was diagnosed just a few days ago. In fact, I haven't even met with my urologist. He gave me the results of my biopsy over the telephone, and I meet with him later this week. So I have a Gleason score 8, 4+4.
Okay.
And I'm nothing but questions. I to what happens next, what I should be asking him. I don't know how aggressive the cancer is. I know that a Gleason score 8 is not a great thing. If it's contained within the prostate or has it spread beyond the prostate, I don't know anything. So any direction or input that I could get in terms of what I should be trying to nail down first, second, and third would be much appreciated.
Well,
Let's ask any questions if I left anything out.
let's just ask a few questions about your biopsy. How many cores did they take, Nick?
I believe that they took 12 cores, and it was an MR fusion biopsy. I had an MRI first, and then I went in for the biopsy ultrasound, which I guess they lay over the MRI.
Correct.
And, right.
And how many of those cores, of those 12 cores, were positive?
2.
2. Okay, so that's the first piece of very important information for us.
Okay, I think I should qualify that though, because there were 2 areas of the prostate that tested positive, but how many cores they took within those two areas, I'm not sure of right now.
Okay, so one of the things that it's good, do you have a copy of the biopsy report?
I do.
Okay, so your biopsy report's going to tell you how many cores they took and how many cores were positive and where those positive cores were. And that's really the starting point. So some of the things that you want to be looking for there are how many cores are in the base, because the base is the worst place to have them.
Okay.
The prostate is upside down, and the base is really the top, and the apex is the bottom. Very confusing. And the base is where it attaches to the bladder. And so the cores in the base are more dangerous than the cores in the bladder, in the apex, in the bottom.
Well, I had one in the base and one in, it was the right base and the right lateral.
Okay. Are those the only two that show up?
Yes, right base and right lateral.
Okay, so you have 2 out of 12, and were they both 4+4?
Yes, they were.
Okay, so that is sort of a tricky, that's sort of a tricky situation, but it's important information. You've got both, you've got 2 4+4. What's your PSA?
The odd thing about my case and my history is that historically over the years, my PSA has always been very, very low. And the hint that there was a problem was through the digital exam.
So is that something?
I believe that my PSA for the past years has been like 0.4.
Okay, what is your PSA right now?
Well, right now, I don't know if you mean that literally or figuratively.
I mean, what was the last PSA that you got, Nick?
0.4.
0.4. All right, so let me give you, I'm going to let Len talk to you a little bit, and Peter isn't on. Is Peter on yet? No, Peter may not.
Here.
Sorry?
Peter is here.
Is he? Peter Kafka? No. Peter Kafka's not on.
Nobody using his name.
Peter Well, I don't see Peter
He's
on.
the last guy. He's the last guy that joined. There he is. He
Yeah,
turned on
he
his
is.
camera.
He's there.
He's-
He's there.
He showed up.
There he is. There
Jump
he is.
up
Okay.
and down, Peter.
Yeah, no, I see him. I see him. So I'm going to let Peter. I'm actually going to let Peter talk to you in a minute. First, right after me. But here's my concern, Nick. And you may not hear this from your urologist. Depends how savvy he is. But a Gleason 4+4 with a very low PSA like that can have some fairly significant implications, because we've seen it many times here. I would rather you have had a PSA of 7 or 8 or 9, but we don't like PSAs of 4. We don't like PSAs of less than 1 when you've got a Gleason 4+4, because it means that the disease could be quite tricky to deal with. Now, that doesn't mean to say that we can't try and get you a durable remission. Cure is not a word that we use when you have a Gleason 4, because we don't know, nobody knows how to cure a Gleason 4 disease. If they tell you they do, then I'd find another doc. But what we can do is find you a durable remission, which is what I have. I had 4+4 disease and I was treated back in 2007. and I haven't had issues since I was treated, thank God, knock on wood. Having said that, many people do have recurrent disease with 4+4, but it sounds like you have a very small amount of disease. So the question is how we best going to treat it. I'm going to ask a couple of people to talk to you. I'm going to ask Peter to talk to you, and then you have a neighbor on this call who is also on the Massachusetts-New Hampshire border, who's just had some recurrent treatment, and he'll talk to you, and then we'll go from there. So, Peter, what advice can you give Nick with 2 cores out of 12 positive, 4+4, and a PSA of 0.4?
What led him to get diagnosed?
What led me to get diagnosed is I had a digital exam, and the urologist believed that he felt something and he wanted to do a biopsy.
And have you had the biopsy double checked, so you're sure that's what's going on?
I couldn't understand the question. I'm sorry.
Can you repeat the question, Peter?
One minute.
Just 1 minute, Nick.
Can you hear me?
Yeah, we can hear you.
Okay. So I was just curious if his PSA was so low, what drove him to get diagnosed? And has he had his pathology double checked to confirm that it really is a 4+4 and everything?
Right. Well, basically, what happened was I had, for the past 3 years, a total and complete loss of libido. And that's what made me go to a urologist.
So, what I would say, it may not have been a bad thing that you went to the urologist to talk about lack of libido, because he did a DRE and he felt something, and you wouldn't have known because the PSA is so low. And very often, disease like that is pretty dangerous, and you don't spot it. So the good news is you spotted it. I think Peter's first suggestion is a very good one, which is that you definitely need to get these cores reread to make sure that it's 4+4 disease. And the way you get a second opinion on these cores is to send them to another lab, and we generally recommend that you send them to Johns Hopkins, to Dr. Epstein's lab, and somebody on this call might be kind enough to put in the link for Epstein's lab if you have it. I have it, but if you don't find it, I'll find it when Len is talking. And all you have to do is to ask your urologist to send out the samples for a second opinion. Where is your urologist? Is he at Dana-Farber or at the Dana-Farber in Londonderry, or is he a local guy, or where is he?
Well, he's a local guy, and I do have initial consults set up later this week with Dana-Farber, but I just haven't gotten that far yet.
Okay. So, Len, do you want to say a few words to Nick? We may have to unmute Len. Sorry, Len. We were getting a lot of feedback from
sorry.
you.
Yeah, this is a puzzle. Nick, this is the lowest PSA that I've ever heard of where someone was diagnosed with prostate cancer and someone had a positive DRE. Usually, when your DRE is positive, when your doctor's able to feel something, it's a sign that the prostate cancer is advanced at least a little bit, and yet your PSA is incredibly low, and you've only got 2 of 12 cores positive. It's a puzzle to me, quite frankly. I agree with Rick that first point of order is to get a second opinion on the pathology report. Make sure you really do have a Gleason 8. And that go to maybe I don't know how far you are from Dana-Farber. It's probably the closest major cancer center near you. I try and make an appointment with someone there. Rick knows plenty of people all over the country. He could probably recommend someone to you.
I have telephone consults this week with 3 different doctors at Dana-Farber in Boston. And one question that I have is that, can Dana-Farber do the reread of the biopsy results, or do they have to be sent to Johns Hopkins?
You're better off sending them to Johns Hopkins because that is the gold standard of the labs. Dana-Farber can reread them for you, but I think everybody on this call would recommend you send them to Hopkins.
Okay.
Do you know how to open the chat window, Nick?
Say that again, please.
Do you know how to open the chat window and go to meeting here?
Chat window.
So there should be a little bubble at the top of the screen.
Chat window. This, is that the chat window?
So there should be a little like question bubble at the top of the screen. I'm not sure. Are you using a Mac or are you using a PC?
PC. Okay, I opened it.
Okay, so you can see that Jake has put in a telephone number. I've put in a link. If you click on that link right now, it'll open in your window, and that will tell you how to get a second opinion from the Epstein lab. Okay?
Oh, yeah, I see that. Okay, great. Thank you very much.
Okay. Now, just before, I mean, we'll just take a few more minutes. I just wanted you to talk to Russ Smith because you guys are probably neighbors. Russ, go ahead.
I just connected my cell phone information. I'm in Londonderry, New Hampshire. So what town are you in?
I'm in North Andover, Massachusetts.
Okay. So I'm close by. I go to Dana-Farber in both Boston. I get my treatment in Dana-Farber, Londonderry. I'm a 4+3, 11 of 12 samples. I'm a year and a half post RP, which is surgery, post surgery. So I have a reoccurrence. So I'm in week 6 of 8 doing radiation. So I'd be more than happy to, be your little bit of a Sherpa and regurgitate the things I've learned here. So if you want to talk, my phone number is on the chat line, and feel free to call me. It's a rocky road, but it's a road that we can beat. And to me, I can kind of feel the end of at least this journey coming to an end in a couple weeks. But it's you need support, you need people with information, and you got to be, as Rick says, be your own advocate. And the only way you can be your own advocate is to be educated and do as much research as you can and come to meetings like this.
I intend on that. Thank you. I do have a question if I have any more time.
Go ahead.
Okay. You know, as I'm sure is the case with everybody, when you first get the diagnosis, you start reading like crazy and watching things, and you're just in total education mode. And I'm learning about this approach from Dr. Ellie Van Allen, the precision cancer medicine. And
Right.
is there any sort of feedback on whether I should be thinking about that at this point, or is that something that should not be on my mind?
It's something that may be appropriate for you in the future, but let's hope that the initial intervention for you is going to be sufficient. Let me ask you one quick question though. Do you have any cancer in your family?
Tons.
Nick, do you have any cancer in your family?
Yeah, yes, tons of cancer.
Okay, can you tell us what that is?
Well, my mother died at 47 years old of cancer. I think it was lymph node cancer, and my father had 4 different kinds of stage 4 cancer. It was bone cancer, lung cancer. So there's been quite a bit of cancer.
Okay, so bone cancer is usually not bone cancer per se. It's usually a cancer that's metastasized from somewhere else to the bones. The lung cancer is relevant. Do you know if there's any breast cancer in your family or colon cancer in your family?
No to both of those.
Okay, so Ellie is a very good friend of ours. We should say up front, a really good friend. He's on our advisory board. We know Ellie very, very well, and he's a compassionate and a wonderful doc. The issue around precision medicine may be relevant, and depending on the cancers that your family had, and you should discuss this when you go to Dana-Farber, they may want to look and see if you have any inherited mutations, meaning mutations, gene mutations that you inherited from your parents. And if you do, then it may indicate drugs that could be appropriate for you if the initial treatment that you choose is not sufficient. We're already looking down the road because these drugs are unlikely to be used in place of an initial treatment of either surgery or radiation of some type or the other. So that is the answer to the question. It could be in your future, but the operative word is future.
Okay, thank you for that input. Appreciate it.
Let me ask you, well, let me first check with everyone. Is there anybody that would like to say anything to Nick before we move on? Anyone else in the group that has anything they feel they'd like to see? Rex, go ahead. Jake, will you unmute Rex, please? Go ahead, Rex.
Hi, age 53, I was diagnosed with a Gleason 8 tumor with a PSA of 2.13, and the biopsy was because I had a palpable nodule on my prostate. This was biopsied, and 2 out of 12 cores were DNA, similar to what you had. They ended up sending those cores to Jonathan Epstein at Hopkins, and they went ahead and upgraded my tumor from originally a Gleason 7 to a Gleason 8. I've had all kinds of treatment, and because I have had recurrence and recurrence. I've gone through numerous treatments and I'm still fighting it today. You really have to stay on top of it, be your best advocate, seek out the best doctors you can find, and treat it aggressively. From the Gleason 8 with such a low PSA of 0.4, I don't think that's a great sign. Like Lynn was saying, it's very unusual. So I think you need to be really careful about who you go see and how you plan your treatment. You only have one chance to have a first treatment of prostate cancer, and you want to make sure that you do the right thing right off the bat.
Thank you, Rex. Anyone else have anything they'd like to add to Dr. Rex? Okay. Nick, do we have, how did you find us, by the way?
Well, since I got the diagnosis, I have just been absorbing everything. So I wish I could give you a very specific answer, but it's just been such a flood of information. I can't recall exactly.
Here's what we need your email address so we can put you on our distribution list so that you get a reminder before each meeting. We meet every week. So you can put that in the chat window, type it into the chat window and send it just to me. You can put it in the chat window, send it to everyone, whatever you're most comfortable doing. But we would like to enter you onto the database if that is okay by you.
Yeah, that sounds great. I'll be sure to do that. Thank you.
Okay.
And Nick, don't be shy. Feel free to call me tomorrow. Be happy to help you out any way I can. Like I say, I got about 18, 20 months of experience, and be happy to help you anywhere I can.
I appreciate that. Thank you very much.
Okay. All right. So what I'm going to do now, we'll move on and let me take a rundown and see who needs time today. I think I've got everybody. If I don't have you, if I don't call you out, then you can call me out. And I'm looking at my list, and of course the name I don't have on my list is Larry Fish. So I better put it on here right now. And I better ask Mr. Fish right off the top, would you like some time today, Mr. Fish?
I was just thinking that you were going to skip me completely. And here you are. But thank you very much. I'm fine for right today. Thanks, Rick.
Thank you. Peter, would you like some time today?
No, I don't think I need any time today.
Okay. Are you feeling okay?
No, I'm feeling pretty crappy, but I can hang in there.
Okay. For those of you who don't know, Peter had chemo on Friday, and so Sunday, Monday, Tuesday are the crummy days. But he had a good day yesterday. Jake, anything for you today?
Peter has been on chemo and he has more hair than most of us. He says his hair is falling out and he still has more hair. But as for me, no, I'll probably have some time next week, Rick.
Okay, with pleasure. Rex, I know you need time. I'm putting a tick mark by you. Nazir, would you like some time today? And you're muted. You have to unmute yourself.
Yes, please.
Okay. John Hall, would you like some time today? And you're muted. You need to unmute yourself. Are you with us, John? You need to unmute if you are. All right, I'll come back to John Hall. Nick, we've done. Sylvester, would you like any time today?
No, thank you.
Okay. Joe Blanchette, would you like any time today?
Yes, 4 or 5 minutes, please.
Okay. Dennis McGuire.
Hey,
would
Rick.
you
Hey, I have an update. I had some PSA work done.
Okay, great. Jerry Pelfrey in San Carlos, Mexico. Would you like some time today?
Yes, I've got my 6-month checkup, so I want to give the information on that.
Okay. Scott, would you like some time?
I'm good, Rick. Thank you.
Okay. Les Shelderup. Any time for you, sir?
No, sir. Thank you.
Okay. Russ, how about you?
Yeah, probably 4 or 5 minutes.
Okay. Len, anything you'd like to update?
Not for me personally, but I think Peter Kafka should have his genome sequenced to see if he has multiple copies of the anti-baldness gene.
Well, you know, if we've got time at the end, we could have a discussion about that. All right.
Sure.
Paul Frieda, anything for you today?
Nothing for me tonight.
Good. We caught up last week, eh, Paul?
Yeah.
David Muslin, I know you need some time to discuss that weird report and see if any of the other guys have got anything. They may have some things that you and I didn't see, so we'll give you some time.
Thank you.
Peter Monaco, anything for you?
No, nothing tonight, Rick.
Al Moskowitz, anything you'd like to talk about?
Yes, I give you 5 minutes. I've got a question and an update. Yeah.
Okay. Carl, anything you'd like to talk about today?
Yes, add me to the list.
Okay, I'm adding you. Ken Anderson, anything? Are you back? Are you in Phoenix?
Nope. One more day and then I'll be back. Nothing for me today.
Okay. I think I got through everybody. Did I miss anybody? Okay. All right. So let me see. Let me just 1, 2, 3, 4, 5, 6, 7, 8, 9. So we've got 9 guys who would like some time. We've got a couple of fairly complicated issues. We will get through everybody. We'll do our best to do it on time. So we've got an hour and 20 minutes. So if we stay on topic, we should be able to move through. Let's start with Rex. And Rex, is it possible for you to get a little closer to the microphone? If you can.
And guys, in the meantime, there's a lot of noise tonight. If you're not talking, please mute yourselves until you're ready to speak, because some sound is coming through very muffled.
Right. And Jake, do you want to open up Rex's mic? Oh, Rex, you may need to open up your. There you go. You're on.
According to me, he's open.
You're open. Let's.
Can you hear me okay?
Yes, a little muffled, but you're okay.
Okay. Not even sure where the microphone is on this laptop, but I'll try and move it a little bit closer. So, should I give a little background about what's gone on in the last 11 years?
Yes. Yeah, not in detail, but yes, it would help, and then you can bring us up to date. I'm pretty familiar. I think Len is too, but not everybody else is.
So I was diagnosed in 2009. Like I said, Gleason 8, PSA 2.13. I went up to Hopkins to have my surgery. My surgery was done by Patrick Walsh. You know, he was pretty sure that he had cured me, but that was not to be, because 3 years later I had a PSA recurrence. So I went up to Hopkins and I had salvage radiation therapy. That was in 2013, and that worked for about a year. because in 2014 I had another recurrence, and that's when I hooked up with Snuffy Myers, and he put me on ADT and got me into a complete remission. And I was on triple ADT for about 7 months, and then he took me off of it, so it was intermittent. But about a year later, my PSA started creeping up again, so he put me on Xtandi monotherapy, and then he retired. So he transferred my care to Dr. Drake at Columbia, and we continued the Xtandi monotherapy until December of 2018, at which time I had a PSMA scan at UCLA, and it showed, multiple mets in my pelvis, intra-abdominal, also showed the first bone lesion that was a spot on L2. So at that point, Dr. Drake put me back on Eligard. I was on Xtandi monotherapy, put me on Eligard to castrate me. 3 months later, my PSA was still going up. So in March of last year, 2019, I was diagnosed as metastatic castrate-resistant prostate cancer. So last summer, I underwent chemotherapy with docetaxel and carboplatin because he was worried that there might be some neuroendocrine component. And I did that for 6 cycles. I had a biopsy of one of my lymph nodes, and it didn't show any actionable mutations, just a loss of P10 and an amplification of the androgen receptor. Went through chemo with some problems because of bone marrow suppression. They had to delay some doses. They had to cut back on my dose. But I finished that in October. My PSA had greater than 50% reduction. It went from about 18 down to 5.8. But 2 months later in December, this past December, my PSA was back up to 20. And I had another PSMA scan at UCLA in January, and it showed much more lymph node mets, much more bone mets. So Dr. Drake and I talked, and we decided that we would do lutetium at Heidelberg. So I went to Heidelberg on January 31st for my first treatment. I thought that it was going to go well because my PSMA scan showed I was intensely PSMA avid, so I thought I'd have a good result. And after the first treatment, my PSA was reduced by about 40%. But unfortunately, what was happening was the lutetium and the actinium were treating my lymph node disease and getting rid of my lymph node disease. It wasn't doing anything to my bone mets. So after my second treatment and my third treatment, I was getting more and more bone mets, even though my lymph node mets were going away. So my last treatment was on May 7th, and my PSA has continued to go up. My scans show that I have much more bone metastases than I did 6 months ago. I also started to become symptomatic with bone pain. Ever since I came back from Germany on May 9th, I've been having significant bone pain, such that now I'm on a fentanyl patch. I have to take Vicodin 3 times a day. I'm currently getting radiation therapy to my lower spine for palliative treatment. And decide, what I'm going to do about systemic treatment. I've burned through a lot of treatments already. I talked to Dr. Drake last week on Tuesday, and we kind of went over some things, but, he wasn't really definitive about any particular treatment. So I'm kind of, for the first time in my life, as to what I'm going to do to treat my prostate cancer now. I think I was most excited about the bispecific trials with Harpoon, the Harpoon trial. The only problem with that is you have to be at the medical center every week, which means I'd have to relocate up to New York. Either that or relocate out to California and do the trial at UC San Francisco, which would probably be better because I have family and friends in the California area. So if I was going to do the Harpoon trial, I'd probably relocate to California. You know, the other things that I could do would be Jevtana, but, you know, my bone marrow is not that healthy. I've got, you know, low hemoglobin. My platelet count is 95,000, and my white count has always been low. So chemotherapy is a blunt-edged sword, and it might suppress my bone marrow even further. You know, I could do exofigo, but likewise, it's a blunt-edged sword, and the exofigo could also do some damage to my bone marrow. You know, other things that we talked about was BAT at Hopkins. We talked about other immunotherapies. We talked about the prostate cancer vaccine. We talked about the androgen receptor degrader. But I never did get a good feel from Dr. Drake as to which he thought might help me the best without causing too much harm. So that's where I am now. I'm going to meet with my local oncologist in a couple of days and run it by him and see what he thinks. But I wanted to come to the group and see if the group had any words of wisdom as to what I should be thinking about regarding treatments or second opinions or whatever in regards to my advancing disease despite all this treatment.
I just want to say one thing to Nick. Nick, feel free if you want to drop off. We've got guys who, as you can hear, are fairly advanced, and you are very, very welcome to stay. But if you're not comfortable listening to some of this conversation, then don't feel at all embarrassed about dropping off the call at any point. Len, do you want to take this first of all and share any thoughts with Rex? We've got to unmute you here, Len. Where's my?
Yeah, I'm unmuted.
Oh, you're unmuted. Yeah.
Yeah. First of all, I have to say that you were coming across very muffled, Rex, and I found it really a strain to hear what you were saying. Of course, from our emails, I know some of what you've gone through. So forgive me if I'm asking a question that you already addressed, but I was curious as to why it is that your lymph node Mets responded to the PSMA, lutetium PSMA, but not your bone Mets. When you said you were PSMA avid when they gave you a PSMA scan before the lutetium treatment. So I was wondering, were both the lymph and bone Mets PSMA avid when they did that scan?
Yes. And when I was in Heidelberg for my last treatment, they do a scan after they inject you with the lutetium and the actinium. And the scan the day after my injection showed that the medication was traveling and settling in the bone metastases, but it just didn't work. And they don't know why. That, you know, it worked for the lymph node Mets, but it didn't work for the bone Mets. I guess it's just a different animal as far as treatment.
And you also mentioned that you underwent docetaxel and carboplatin for the possibility that you had some neuroendocrine disease, but did they ever biopsy any lesions to validate that you did have neuroendocrine, or was that just a guess?
It was Dr. Drake's suspicion based on the amount of my disease with a low PSA. I did have a biopsy of the lymph node. It did not show neuroendocrine. It was just carcinoma, and that was in March of last year. I really need to get another biopsy, I think.
when was the last time that you had genomic sequencing, Rex?
That was when I had the biopsy done in March of last year.
So, you know, it's over a year, it's 15 months, and if you can figure out how to get sequenced again, particularly from a solid tumor sample, you know, that is certainly one option. And, you know, with Foundation Medicine, as you know, it's just right. It's still one cancer, one lifetime, although we think that's changing. At the same time, Peter just heard last week from Caris that they said the Caris is saying it's once a year. So, you know, you might get some joy out of sending it to Caris, but I know that Foundation Medicine is still one cancer, one lifetime. I do think that, and New York Presbyterian may even be able to sequence in-house as well.
Yeah. Dr. Drake likes using Caris for his sequencing.
Okay.
So imagine if I get a biopsy, it'll probably be sent to Caris.
Okay, I mean, that's fine. I'm going to open it up to everybody else, but my thought, as you know, is if there was a way to get you into one of these trials with either the Regeneron or the AnCan or the Harpoon, where they've got these drugs that seem to be able to attract a T cell with one arm and are attracted to the prostate cancer cell, or the prostate cell with the other arm. You know, that is exciting, and so far you haven't tried any sort of immunotherapy type treatments. Do you know what your tumor mutation burden is, or your MSI reading, or any? You don't. So I definitely think that that didn't register on the last Foundation Medicine. Was it unmeasured? Was it unspecific, unmeasurable?
I have not had any samples sent to Foundation One.
I'm sorry, you haven't had any.
I haven't had any samples sent to Foundation.
Oh, you've never had any samples sent to Foundation Medicine. Well, you know, I think that I don't know if Caris measures that, but I think that it's worth going through the measurements that would indicate whether you're a good candidate for an anti-PD-1, anti-PD-L1 drug. And if you have a high tumor mutation burden, and if you are MSI high, microsatellite instability shows a high number, then you could be a candidate for an anti-PD-1 or an anti-PD-L1. But, you know, as I've said to people on this call, it doesn't make sense in my books. For me, I would not submit myself to that type of a drug unless I knew that I was a good candidate, because the downside risks are too great. I mean, I don't have to tell you that. You understand what they do to your immune, how they can act on your own system, the autoimmune effect. And, you know, we've known people that have had their thyroids absolutely destroyed by this. So, and that's just one thing. I mean, you know this, you know it inside out as a doc. So
if I were to have a biopsy of one of my bone tumors, and would it be worthwhile to have a liquid biopsy as well sent to Foundation Medicine? Would it be beneficial to have both a liquid biopsy and a solid tumor biopsy?
Well, look, we've seen that very recently. Barbara Discant isn't on the call today, but her husband just sent liquid and solid tumor to to Foundation Medicine, and they came out with different results. And so it's posing a problem because they found a mutation in ROS1, and it's not really clear if that was a false positive or not. Foundation Medicine always says that they get better results from solid tumor than they do from liquid. So, Nazir, who we'll talk to in a minute, just sent a liquid biopsy to Foundation Medicine, and his MSI was undeterminable, so he didn't get a result. And we've talked about, is there anything more that can be done? And they say no. If it were me and I wanted to know my MSI and my TMB, I would want to send a solid tumor sample to Foundation Medicine. I think that's the best I know, unless Drake has a better idea. But I would be asking Drake, are we going to get an MSI and a TMB result out of Caris? Because if not, I'd rather send to Foundation Medicine. So I don't know if Caris reads for MSI and TMB.
Yeah.
But I
had out before I had the biopsy.
Yeah, but I mean, I do think that yes, it makes sense to get a biopsy. I do think it makes sense to, maybe think about doing this harpoon study with Larry. We know another guy who's doing it. I know Larry really well, and I'd be happy to make. I mean, and so does Drake. But I mean, I know him on a personal level, and I'd write to him in a heartbeat for you, and see what he says. He's a very different personality to Drake. He's very warm. He's very personable. He's not as aloof as Drake is. He's just a different character, and he's great. He's just great. So we'd be happy to do whatever we can to help you get in to UCSF. And then, I think I'd be looking at one of those three. And then if not that, I'd be looking to see if I'm a good candidate for immunotherapy right now. When I say immunotherapy, I don't mean the trial immunotherapies, but I mean the approved, like an anti-PD-1 drug. And what the other thing, and again, I'm not really an expert on this at all, but it seems like the anti-PD-1 is a better option than the anti-PDL1. Just, this is my gut. The results from the anti-PD-1 are better than the anti-PDL1. So anyway, anybody else want to come in? Anybody else want to say anything on this issue before we move on?
Yeah, Rick, it's Len. Rex, I had looked into this clinical trial for someone else with advanced prostate cancer. He couldn't travel, so he couldn't enroll in this clinical trial. But in the event that you do not have, if your MSI is stable, if you don't have a high tumor burden, so if your tumor is cold, there is an experimental drug that's being used with pembrolizumab to turn a cold tumor into a hot tumor, make it more receptive to treatment with pembro. I'm going to paste this into the chat box there. It's called Talabostat. It also has a lab name I'll try and come up with in a minute here. I'll add that. Oh yeah, I have the trial here. I have the clinicaltrials.gov trial number. which I'll add in there. So if you want to talk to Charles Drake about this particular trial, just get his opinion on it. Might be worthwhile.
Okay. Is there a way that I could talk to Dr. Fong or his team about this trial going on out at UC San Francisco? Is there a way I could talk to someone on his team about that?
First of all, I think it's the same trial that Drake's doing. It's the HPN trial.
Right.
So, I mean, the answer is yes, but it's exactly the same trial that Drake is offering. And if, you know, my suggestion is talk to Drake about the trial, but if you would rather do it in San Francisco than do it in New York, if that's your decision, then I'll connect you.
Okay. But if Drake says that I'm a candidate at Columbia, then I should be able to get into the trial.
Yes.
Right? Which is the exact same trial, right?
Yeah, I'm pretty certain it's the exact same trial. I mean, look it up on, I looked it up the other day. I can't do it right now, obviously, but I looked it up the other day, and I'm almost certain that it's, you know, the Harpoon trial and the locations that are listed on clinicaltrials.gov or New York Presbyterian. There's about 4 locations. I think that Larry might be the PI, but I'm not certain about that.
Okay.
Okay, but all you want to do is, if you decide that's what you want to do, just give me a shout and I'll drop Larry a note in a heartbeat. And he's usually pretty good about getting back to me. You can see the stuff that's put in the chat window, right?
Yes.
Okay, great. And by the way, everybody, if you're on, I can't tell you if you're on a Mac, but if you're on a PC, you can find the chat window. After we close out, it'll be in your documents file. And we post it with the recording. So I just wanted to mention. Okay, we're going to keep moving along. I'm keeping an eye on the time here. We've given Rex, you've got a couple of things to work on. I mean, we came up with a couple of things for you. So Nazir, why don't you tell us what's on your mind?
Yes, I just wanted to ask you a question here. That one oncologist tells me that you should go for the trial with Keytruda and Xtandi. The other one says it will not do you any good after looking at my sample that came from Foundation Medicine. What's your view on that?
Okay, so we need to fill people in a little bit about your disease. Let me just pull up your record, because I don't want to misspeak here. So Nazir was diagnosed back in 2009, and originally he did IMRT, and the disease recurred clearly around mid 2014 to 2015. The scans seemed to show that there was some lymph and spinal involvement back in 2014, but the urologist and the radonc that Nazir was seeing at the time, I should add, Nazir lives in Niagara Falls, Ontario, so he's getting treatment in Canada. And you know, my own feeling when I spoke to Nazir originally was I thought that the urologists and the radiation oncologists weren't really on the money. He started Casodex and Lupron finally in the beginning of 2016, and he did docetaxel at that time. had a few issues with the steroids, but we resolved that. And he's sort of done pretty well from there on out, but the PSA just kept climbing very slowly. He was still on the Lupron in 16, in 17. They played again around. They added Casodex back in again. Let's see. They took the Casodex out. And then in May of 19, Nazir started Zytiga. And so that's pretty much what he's been doing since. And his PSA has been going up, and eventually it got to a level of around, it's been holding steady for the last 3 months at a level around a level of about 20. When he started the abiraterone, it was at when he started the abiraterone, it was around 3, somewhere, something like that. So it's climbed up to around 20, and it seems to have stabilized. Now, there are some trials that are going on at Juravinski in Ontario, in Hamilton, that include Keytruda, pembrolizumab, and enzalutamide. And the trial, I think, is enzalutamide versus Keytruda plus enzalutamide. We said to Nazir that he needs to know if he's a good candidate for enzalutamide, because even though he looks 65 when you look at him in the screen here, he can fool, he's fooling all of you because he's really 83, God bless him. And he's a very, very healthy 83. And we know that pembrolizumab can be a nasty drug. And so we said to him, you know, make sure that you're a good candidate. So he went to Foundation Medicine through Canada, and they tested his, he did a liquid biopsy because he does have Mets, but the Mets are in his ribs and in his lymph node, and they're not biopsyable. And the result came back that he had CHEK2, TP53, and FGFR1. Only the CHEK2 is actionable, and it's actionable with a PARP inhibitor. However, it's never seen a response in prostate cancer. They've only seen a response to CHEK2 in breast and ovarian cancer with a PARP inhibitor. And his MSI was undeterminable. So that is the summary. So that's the background to the question, what should I do? Now, I have suggested to him that there's nothing in the FMI that suggests that he would respond well to enzalutamide and or pembrolizumab. Doesn't mean he wouldn't, but there's no indicator that he would. That he has done well on chemo in the past, and maybe a good way to go would be to try Jevtana, which has a lower side effect profile. And so Nazir's question is, what do I do? I got one doc who's saying, do the trial, and I've got another doc that says, doesn't make sense to do the trial. And he's had a consult with Alicia Morgans too. Now, let me ask you, the guy that thinks you should do the trial, is that the doc who's running the trial?
No, this is Dr. Morgan.
Dr. Morgans thinks you should do the trial.
Yes, in the absence of other treatments, she said, just try it. It may work, it may not work.
And who is the doc who thinks you should not do the trial?
Okay, after looking at this document, my oncologist, Dr. Levesque, says that you'll be wasting your time on that one.
So, okay, everybody has the background. Who wants to chime in?
Rick, I just recently blogged about this from the ASCO 2020 virtual scientific program. They did a phase 2 comparison of people with metastatic castrate-resistant prostate cancer like you, Nazir. And they compared Jevtana, cabazitaxel, to lutetium 177 PSMA.
Yes.
And the lutetium was superior to people with your background. So, if you can get a PSMA scan like Rex did and see that you're PSMA avid, that in other words, your prostate tumors are expressing PSMA, that might be a better choice according to that phase 2 trial. So I would say talk to your doc about that.
Where's he going to get lutetium then?
Well, I guess like Rex, he has to go to Heidelberg.
Yes.
I mean, that's a pretty expensive option, though. I mean, that's a very, very expensive option. I mean, you've got to be able to afford to do that.
Yeah.
Anyone else have any thoughts? Go ahead, Rex.
Would he be a candidate for these bispecific trials that have been suggested to me, either the Regeneron, Harpoon, or Amgen?
I don't think they're going on anywhere in Canada. That's the problem. And so, what we're trying to do is find an option that is local. I can only tell you, if it was me, I wouldn't mess with first of all, we don't really know if the enzalutamide is going to work for you. What we do know is the abiraterone has been holding your disease. And as I said to you, I might go another couple of months and see if that abiraterone continues to hold, or even if it starts to dip down.
Okay.
But as soon as it starts up, then you have to be prepared to respond. Would I do the Keytruda? If it were me, I would not. If I wasn't a good candidate, but that's just me, what I know. I would probably, especially since you did well on the docetaxel once before and it gave you, I would try the Jevtana again and see how you do on it, the cabazitaxel. But I don't think that I think this is something only you can resolve.
But Rick, didn't you just say that Nazir's PSA went from 3 to 20 while he's on Zytiga?
It went from 3 to 20, but it's now plateaued at 20.
For how long?
Over 3 months. So it got up to, and we started working on these options when it was going up like crazy. But the last, from early April until June, it's fluctuated between 20 and 22.
Okay. Well, I agree with you that Xtandi is probably a long shot. I don't I can't see that that's going to help much. But I mean, typically, when you're no longer responding, even if you're just stable on Zytiga, and then you switch to Xtandi, your chances of having success there are less than 15%. And even if you do have success, it's typically very transient, like 3 to 6 months.
One more question, if I may. This document says that olaparib was one of the treatment.
Olaparib.
So will that work for me?
No, as we've discussed, it says olaparib because you have a mutation in CHEK2.
Yes.
Right? But in theory, it means it should work. And we've seen it work for people who have that mutation, who have ovarian cancer and who have breast cancer. But we've never seen it respond in prostate cancer. So they are telling you that it should respond based on other cancers. But we've never seen it respond in prostate cancer.
Yes. The reason why I say this because there are 1, 2, 3, 4 trials listed with that over here.
I mean, there could be 10 trials listed. We still haven't seen it respond in prostate cancer.
Okay.
We've seen CHEK2 respond, but in other cancers, you can try it, but we've never seen it respond.
Okay. That's good.
You know, so they're telling you, yes, CHEK2 is an actionable mutation. It responds to olaparib. But call them up, as I suggested to you the other day, call them up and say, has it ever responded in prostate cancer, and see what they say.
Okay, thank you.
Okay, we got to move along because we got a lot of guys here and we've got a lot of people to get through. Joe Blanchette.
I picked about mid-May. I picked up some perineum pain, and I don't know what that's from. Some background on that: I've had a yeast infection in my perineum for the past 10 years. My primary care doctor put me on clotrimazole and then nystatin cream for the past 3-4 years. I went back to that doctor because I'm hurting exactly where I put the cream every day. So, but I'm so far, I've taken she's given me PSA tests. She's given me, I'm going to go in this coming Wednesday for a urine test. And she put me on 10 days of Keflex. And so I believe I have some swelling in that area, and I might have a skin infection in that area, and I don't have a prostate anymore, so might be something with the bladder. I do get up 5-6 times a night with the bladder, and over the last 9 years or so, it's been slowing down. I probably retain urine in the bladder also, more so than I ever did before. A year after my prostatectomy, the same doctor went back in and made a cut at 3 o'clock and 9 o'clock in my sphincter underneath the bladder to expand that gap. So I don't know what's going on. The question is, has anybody experienced perineum pain before, and what was the cause of it?
Well, this is certainly out of my realm. I have not, and I'm wondering, has anybody else had any? So the perineum, I should explain is the area between, correct me if I'm wrong, Dr. Rex. I gotta be careful here. I gotta be careful here. But it's the area between the anus and the scrotum, isn't that right? No?
That's correct.
Whoa! Thank God! Thank goodness! Thank goodness! Has anybody had pain in the area, in that area, and that they could throw any light on this issue for Joel?
And another byproduct of this may be the fact that I had a radiation SBRT in February, 3 treatments, and my PSA went up after radiation to 1.76, went back down to 1.3, down to 1 last month, and now because she gave me a PSA in June, it's down to 0.8. The PSA is going down. But after the SBRT, but I don't know if that has anything to do with it either. I'm seeing my radiation oncologist on the 23rd of June, and I'll see what he says about my situation now.
I mean, I don't know that we can add much for you. I'm sorry. We just don't have we're not docs. We don't have the experience. Most of us are not docs. And we don't have the experience. So, you know.
Joel, I have a question. Is the pain internal, or do you feel it on the surface?
Well, it's a good question. It's sort of internal, but it's not far internal. It's like maybe half an inch below the surface, or a quarter of an inch below the surface. There's sort of some swelling there. So it's hard to pinpoint. The docs asked me if I was above my pubic bone, like where my bladder is, and I said, no, there's no pain there at all. So it may strictly be a perineal pain. I am not sure what's going on.
Yeah, I get some pain, perianum pain, but I can palpate a little bump underneath, like a quarter of an inch under the skin, that sometimes seems to swell and get infected because I'm heavy, and it's like if I'm exercising, walking, I think it gets sweaty down there, in there, and there was a point where they wanted to maybe drain it, but they let it go and it burst by itself. It was a little blood, and that's been repeating with me over the last 2-3 years off and on. I took it to my oncologist because there were some lumps there. She didn't think it was any reason to biopsy it because it felt kind of hard when it swells and then it drains. So you don't have that where it reaches the surface and you can palpate something. I went to my local primary care physician. She is the one who sort of palpated. She said she felt it before with other people, and that you can just sort of wait it out, or you can try to, drain it if you want. And we just waited it out, and then was bleeding over a day or two, and then its pain went away, but it recurs. I looked it up. I had some names for it. I spent a little time doing research. I forgot. It was a couple of years ago. But they said it, they had a name for this, and it repeats. Sometimes they say it can turn into a mutate into kind of a cancerous growth of a different kind, but it never did. And so I just live with it off and on. And if you try to do squats where you touch the chair and come back up, that's where I really can feel it. Do you feel it like if you sit on it?
Well,
try a ring.
That's the problem. If I'm walking or standing, I don't feel any pain. If I'm sitting down, which I do most of the time, I feel pain.
And you mentioned the ring didn't help you, a ring seat? You
No,
get like a ring pad for your chair?
That leads me to another point. After I came back from Vietnam around age 25, I was diagnosed with prostatitis, and I got given Septra by the doc, and that Septra made me, I was allergic to Septra, and it attacked my lungs and liver. And so, but I've had that prostatitis pain all my life, off and on. It's a chronic pain. And I thought I would get rid of it when I had my prostate out, but it was right there, still there. It didn't change a bit. And so the best thing that happened to me was my urologist sent me a prescription to a physical therapist. And I learned that by extending my ligament after you exercise, I stretch my legs, and the ligament goes right into the groin where the pain is. So if I stretch my leg muscles after exercising, it helps that pain a lot. But this new pain is different. Now, it could be a continuation of that pain that's inflamed or something. I don't know. But,
All right, it seems so complex, and I know Rick. I can see Rick is starting to get anxiety at the edges about moving on, because I don't think we're going to resolve it. But I found that a ring, one of these padded rings that you get to sit on, I found that helps me.
Okay, great. Appreciate it. Thank you.
Okay, I'm sorry, we do have to move on. I don't know that we can, hopefully what Larry told you might give you a couple of clues, Joe, for your conversation with your docs. Okay, Dennis McGuire.
A quick update. So I completed radiation in April, and at that time my PSA was 14, and I had a 6-week update last week and had some blood work done, and the PSA was at 6.
Ooh.
So there definitely is some improvement. The docs are hopeful it will continue to improve, so it's too early to celebrate, but it's going the right way.
Well, that's good news. 6.0 is that, Dennis?
5.9.
5.9. Okay. Hey, let's squeeze everything out of it that we can, man. So I see it was 14.5 when you started the SB. Yeah. Look, I mean, it's heading in the right direction, and you just got to stay on top of it. Anybody else have anything that they want to add in encouragement to Dennis based on their own experience when they now let me just check one thing with you. This was not was this to treat the prostate or not? I can't remember.
Yeah. Yes, it was prostate.
Yep.
As well as one left iliac node and a spot on my hip bone.
Yeah. Ken Anderson, you're there. How much did your PSA come down after they treated the prostate?
I'd have to go back and look up my notes, but I think it went from like 6 to, it was pretty low. I think after they treated the primary, I think it dropped down below like 0.4. So I got a good response out of radiation. I did. And I did IMRT though. So, but they treated the primary just as you did, and some lymph nodes.
Mm-hmm.
So hopefully you'll get a good reply. I know you were worried last time we chatted that it was not coming down, but happy to hear that it did.
Dennis, did you continue ADT while you had the SBRT treatment?
I did. So I continued Lupron and also Xtandi.
Okay, good. Glad to hear it's going down.
Thank you.
Dennis, I happen to know that Mr. Anderson would like to chat with you. So do you guys have each other's contact details?
Yeah, let's do it.
Yeah, we do. Yeah, we do.
Okay,
So
just
I've just
saying.
been traveling. Yeah,
Oh,
thank you, Richard.
okay. All right. Let me just make one other note here. So you continuing LHRH plus ends. Okay. We keep sending out the good vibes for you, Dennis.
Thank you.
All right. Let's talk to Jerry Palfrey. Jerry, you have your appointment coming up in Phoenix with Dr. Singh, correct?
I just got back from it.
Okay.
Do you want a little history or just real quick to give you the results?
Well, you have to give a little bit of history, but keep it really short because we've half an hour. We've got 3 or 4 guys.
Yep. I was diagnosed February 6th with advanced prostate cancer. The PSA was 3,194 at Mayo Clinic. So obviously metastasized all the way up my spine, around my pelvic girdle, and in my shoulders. Some spots on the skull a little bit. And so right away went in with Singh on I'm on Lupron and Zytiga. And
Jerry, can I just you said February 6th of 2019.
Yes.
Right, you left out the 2019.
Oh, sorry. I'm getting a little of that brain crap.
It's okay.
So anyway, it took my in January, or well, December 4th was the last time I saw him. My PSA then was less than 0.1. So this is the next time that I saw him, and we did a CAT scan of the shoulders, abdomen, and pelvis. And then we also did a total body bone scan. All of my chemistry, all my lab work is fine. My PSA is 0.05, and he did a testosterone for me, and I have the number 7 for testosterone, which goes right along with a 0.05, so that's okay. The good news is I have absolutely no new cancer anywhere from those 2 exams. I know they can't tell the small stuff, and one of these days I'll have to have the PSMA, what is it, 68 MRI?
Yeah.
But for now, nothing. He said, I'll see you in 6 months. Have a happy life. So we're rather pleased with that.
I think you should be. I think you should be. That's a good report, and you know you're holding in place with the Zytiga pretty good. It's keeping you where you want to be.
Yeah, except I don't want to keep taking it due to the potential side effects.
Well, one of the side effects is almost 0 PSA, and you're still with us. Those are the good side effects. Jerry, what was your Gleason score?
9. 11 of the 12 were infected. There was only 1 that wasn't, and I can't tell you all of them. I had 2 4.5s. I had 4 4.4s, And then there was a 7.3, and I can't remember the rest.
No, it doesn't matter. But a question I have is, what did you decide to do getting a palliative doc on your team?
I talked with Dr. Singh about that, and he said, "You're doing well. You don't have any problems." He said, let's wait for a while because there's really no need for palliative care right now.
Okay. Well, palliative care treats symptoms. So
Oh, I know.
So if you got symptoms, that's where the need is. And one of those symptoms, if you're having the brain fog, they've got tricks up their sleeve that can help you with that.
Well, that's good to know. I'll have to email them and ask them about that.
Okay. Yes. I mean, there are things that they can do. Small doses of Ritalin, for example, have been known to be effective.
Yeah, I just don't like to keep taking so many pills. But when my wife, sometimes it's nice to forget, but with a wife, but not this time, not these times. I just seem to, I say something and forget about it. So that would be a good idea to check on.
Okay. Okay. All right. So anybody would like to say anything to Jerry about his continued success with abiraterone?
That's just miraculous, Jerry. An incredible response for a Gleason 9 to go down to practically undetectable from 3,000. It's astonishing.
Yep, congratulations.
All I can do is thank the universe and say that I did everything I could to help.
Tell that good wife of yours that we expect to hear her voice on the Caregivers call tomorrow. Okay?
Yeah, she's already set up.
Okay.
We couldn't do it because we were driving up to Phoenix on the last one. She had to skip it.
That's okay. We've got one tomorrow, and we'd love to hear her voice, and hopefully she'll sound as relieved as you sound.
Oh yeah, she is.
And for all you guys that are on this call, if you've got a significant other, we do have this caregiver call twice a month, and we do keep a Chinese wall, as they used to say in my banking days. They do keep a Chinese wall. We keep a Chinese wall between the calls. So what gets said on that call does not come back here, and vice versa. So just to sure, so if any of your significant others would like some support, they are very welcome to join that call. So we've got 3 folks left: David Muslin, Al Moskowitz, and Carl Foreman. David Muslin.
Yes, sir.
So I think we should probably just tell these guys about the conflicting information from your scans and ask them what they think.
Yep, I think that would be good. You want to give them the results or fine, Rick?
Say that again?
You want to give them the results or should I?
You do it.
Okay.
I'm testing
On Friday,
to see how you do. I'm testing to see how you do with Maha Hussein tomorrow.
Yeah. So I've got that scan Friday, and I got a bone scan.
Let me interrupt you. Your mic is not very good. We're getting a lot of interference as you speak from your mic.
Okay, give me
So
one second. I'll fix it. 1 second and I'll fix it.
Okay.
I think it was Jerry. I muted him.
Interference from Jerry. I think it was Jerry that was interfering.
I muted him.
Okay.
Is that
Sorry.
better now?
Yeah, that's great.
Thank you, Jerry. Anyway, so bone scan and 2 CT scans, and the bone scan came back pretty much. Oh, by the way, let me just back up. And I did my second PSMA scan at University of Michigan in January of this year. So, and they did a lot of comparing in this report. The bone scan came back pretty much negative, wouldn't you say, Rick?
Yeah, that's what they said.
Came back negative, but the CT scans came back saying that saying that I have 2 tumors, one on rib 3 and rib 9, and that those tumors are getting bigger and growing. They went from 0.6 to 1.0 centimeters. And I have an appointment tomorrow with Maha Hussein, who I think we all respect a lot. I think you called her once Rick a sage. And
Yeah.
And that's the story. And one other thing, my PSA, I'm on Lupron, just on Lupron, and my PSA continues to come down, and it came down over the last month from 0.2, now it's 0.17.
Okay. So the issue here is that the bone scan and the CT scan of the abdomen and the chest all acknowledge these lesions. They see them in all 3 scans, except the bone scan says we see it, but the uptake isn't that big, but it's there. And we saw it last time, and these are the same lesions that showed up on the PSMA report. And the CT scans say the size has gone from 6 millimeters to 10 millimeters, but there's nothing to think that this is metastatic, which I just find a little strange. And I'm just wondering what other people might say or think if that was what it was reported. And David and I spoke earlier today, and we're going to try and, David's going to try and hone in on this with Dr. Hussein tomorrow and see what she thinks. I mean, to me, it sounds like the radiologists are kind of waffling, and they're not willing to defer to the better technology of the PSMA scan. Anybody want to comment on this?
Yeah, I agree with you, Rick. They should probably have a PSMA scan. Actually, you put the decimal point in the wrong place. It was 0.6 to 1 centimeter, not 6 to 10, right? Is that right?
No, I said from 6. No, it went from 6 millimeters to 10 millimeters, or 0.6 centimeters to 1 centimeter.
Oh, okay. You were using millimeters. Sorry, he used centimeters. You used millimeters. I missed that.
Yeah.
Okay.
Yeah.
Yeah. Well, anyway, I agree. I think I would do a PSMA scan if you could, or get gallium or PYL, whatever you can get.
Would you think to do it again right now with such a small increase, though? I mean, you know, the
that's right. Your PSA is actually dropping while the so-called metastatic lesions are growing. So there's some disconnect there.
Yeah.
Sometimes, the CT scan will pick up what appears to be a lesion, but it could just be a stress fracture or something like that. But the fact that they say it's growing is puzzling.
Right. And they say it's growing because they took the measurements from the PSMA scan.
But you had a PSMA.
I've had 2. I had one in January of this year, and I had one back in June of last year, July of last year.
Oh, okay.
And by the way, Hussein says that once you start Lupron or LDHD drug, she said you can't do a PSMA scan again. You don't get the same reading as well as you did before. I think everybody, is that
Right.
okay with
Okay.
that?
Yeah.
Is that right, Len? I mean, does the Lupron affect the avidity of the PSMA?
Oh, well, they usually want to do the PSMA scan when you are not on any ADT drugs because, you know, the ADT drugs could bring the PSA down too low to be detectable. I think that's the main reason.
Yeah.
And in your case, you know, 0.17, there aren't many scans that are going to pick up anything.
Right.
So, you know, the one thing that occurs to me, David, and this might be worth pursuing too, is that what looked like 0.6 centimeters on the PSMA scan could look like 1 centimeter on the CT scan, just because it's not as definitive.
Mm-hmm.
You know, so it might be, I mean, 4 millimeters isn't very much. And I'm wondering if it's just a measurement error, and that might be something to ask her.
Mm-hmm. Okay. I will ask her and I will report back next week, gentlemen, and let you know exactly what she said. I don't want to hold everybody up. So it's interesting. It's somewhat good news.
Yeah.
With the PSA going down, and we'll see.
Yeah. No, I agree with that. Anyone else before we move on?
I just want to say one thing to Jerry Pelfrey. Jerry, enjoy the next 6 months. I'm so happy for you.
I'm sorry?
I say enjoy the next 6 months. It's big time exciting news, and I'm very happy for you.
Oh, thank you very much, and I sure am going to enjoy it. Believe me.
Thank
you.
Thank you, David. That's very nice. All right, let's talk to Alan, and then we'll talk to Carl. By the way, this does reflect how you guys joined the call, the point at which you guys came in on the call. I'm just saying, because I write them down that way. I don't always do that, but I did today. So Al, again, most guys don't know your story. Give us a very, very quick update.
I'll make it very brief. Sure. Look, I had prostatectomy in early 2013. Everything looked good. Gleason 4+3, and over a few years later, PSA started to creep up, and I had radiation treatment concurrent with Lupron, and then of course PSA went down, and then subsequent to that, PSA has slowly crept back up. And it would creep up roughly, varied from 0.2 units every quarter to 0.3, and then it would pick up and it went up to about 0.4. Over the past couple of years, I had a PSMA scan at NIH that found nothing. I had an Axeman scan last November that found nothing. And then I had another PSMA scan this past March, which found nothing. And here's what's interesting. Back in December, I had a PSA reading of 2.1, and it jumped up approximately 0.5 from the previous quarter. And I was a little surprised because usually it was about 0.3 or so, but I said, okay, things are, picking up. Well, most surprisingly, this past March, the PSA only went up 0.2. So it jumped from 2.1 to 2.3. And I said, well, that's interesting, but, you can get an anomaly here and there. and I didn't think much of it. Well, the last week I had my June reading, and the PSA was identical, within like the 100th place. So it was 2.31, and the June one was 2.33. So I was very happy. I believe the numbers. And my question for folks is, well, what's going on? Has the rate, I'm sorry?
No, we didn't, nobody said anything.
Okay, so the question has an echo. Has the radiation finally worked? Yeah, picking up and get off speaker, maybe that'll help. Has the radiation worked over a period of time, or is somehow the cancer reached equilibrium and I'm gonna, be lucky and keep it at this level? Hey, what's everybody's thoughts? Because I have to tell you, I'm most surprised.
Well, I think most people's thoughts are you're a lucky guy because a lot of guys on here would trade for your situation right now. The radiation, when was it? How long ago was it you did all that radiation?
Sure, it concluded the end of May 2016. So you're talking 4 years ago.
No. I mean, I think it sounds like there isn't much going on. It may have something to do with even some prostate tissue that's in there, but then why would it go up to 2.33? I don't know. Have you switched to Dr. O yet?
Not yet. I was waiting for this result. Now I may wait for the September results before I see them.
Well, the reason I ask, Alan, is because Dr. O is the most likely person to have an answer for that. I mean,
of course.
We can't say why nothing's happening. You're not on any drugs right now, is that right?
That's correct.
So you're not on any drugs. You're not on any type of androgen deprivation therapy. Your PSA has stabilized. We can't see anything on the PSMA scans. Len,
nothing on.
Well,
all the way
he's likely to tell you.
It's all probably micrometastasis, and that's why it's not showing.
Right. So, Len, what do you think?
I was about to say that Dr. O may very well likely tell you the same thing he told me, where he said sometimes PSA just plateaus indefinitely without any treatment. I had a PSA of 0.6 for something like 16 months, I believe, before it started going up. And I wasn't on any therapy of any kind, and I'm a Gleason 9. So he may tell you the same thing. Your plateau is at 2. And, cancer cells do enter a dormancy stage from time to time. And that may be what's going on with you right now. You've got your cancer in a dormancy stage. It's just not growing for whatever reason.
Fair enough. All right. Well, I'll see him hopefully in the early fall, and we'll go from there. Very good. Thank you.
Okay. And Mr. Last but not least, never least. This will teach you to get on the call at 5 minutes before the hour, right?
Boy, well, it was such a beautiful early evening here in central New Jersey. It was in the mid-60s. I was walking around the neighborhood, and then I had to run home to get here on time. And now it's almost time for me to go to sleep because my nap time is,
well,
10 p.m. here.
Let me just say, it must have been very nice because the person who came on right before you was also enjoying the neighborhood, was your neighbor, Al Moskowitz.
There you go. We're both from Monroe Township. That's right.
There you go.
So I had my latest oncologist appointment this morning, actually, and it was via telemedicine, as had been previously scheduled. And the day before, on the Sunday, believe it or not, I had an appointment with my primary care doctor Sunday morning at 9:30, and saw him in person. So, but anyway, the oncologist, the story with him is that my PSA, based upon me being on olaparib for over a year, and has been undetectable, and continues to be, I don't know if we can call it undetectable anymore, but it's very low. The PSA has gone to 0.02 as of 6 weeks ago, and as of last week it was 0.05. So it's still very low. And I asked the oncologist, I said, can this be attributed to the fact that we've been quarantined, not doing anywhere near the exercise that I was doing previously? And he said, sure. I mean, that could be a factor in just slightly raising my PSA. So he wasn't concerned in any way with the numbers. And he actually said the olaparib, he can see me continuing on the medication through the end of the year, if not into sometime into 2021, to continue on the olaparib, because I had brought up the point. I said, well, studies have shown that olaparib would, the average effectiveness is about 9 months. So I'm beyond that. And I think Professor Bill was also beyond that point as well. And, you know, I'm not going to look a gift horse in the mouth, as they say. And so that's my story.
So it's a good story. I mean, so you're saying that the 0.02 was about 6 weeks ago.
Right.
So I have a question. Have you tested out those classes that we asked you to test out?
I tried one initially. It wasn't a live class, but I've been remiss in doing that. I know that Len has given some positive feedback on it. I think Peter has also tried doing it, but the latest here in New Jersey is that apparently the gyms will hopefully open up in the next phase, which could be within the next 2 weeks. I've already spoken to people at my gym, and they actually installed a new ventilation system that's supposed to be very highly efficient, that they typically use in operating rooms to keep the air as clean as possible. So I'm looking forward to getting back there.
Well, I have just forwarded to you this week's class schedule. live class schedule. Okay? So if you are concerned about not doing enough exercise, then try these classes. I think we will probably launch them to everybody very soon. I need a couple more reports. I need you to try them and tell me how you do. And it'll kill 2 birds with 1 stone. You'll be doing everybody on AnCan a service, and maybe we'll get your PSA back down to 0.02.
Okay.
But, you know, again, hang in with the olaparib. And, you know, the one thing that we really don't know, and I would have, you know, I really would when you said you saw your doc, this was this wasn't Drake, right? This was your
no, Cancer Institute, Dr. Soraya.
Soraya, that's it, Soraya. So and you know, it's good. I mean, it's good. I mean, I'd like to know what their view is on whether the second-line PARP inhibitors, if the second-line PARP inhibitors could be more effective when if and when the olaparib stops working, you know, maybe switch onto one of those pretty early on, because that's what Bill thought. but of course they weren't approved the way they are now.
Right.
Anyone else want to say something to Carl? Len, anything on your mind?
Well, let Rex go first.
Can you tell, Carl, can you tell us why you're doing so well on this olaparib?
Why? Well, I mean, I had genetic testing, and I do have a mutation. I have a BRCA2 mutation, and based upon that, when the so-called precision medicine, it was determined that olaparib should be the most effective medication for me, and the studies with olaparib and BRCA2, I mean, they're saying upwards of the 80% success rate for those of us who have the BRCA2 mutation. So far, so good.
And I just would like to point out to Nazir that the mutation that Carl has is right in the sweet spot for olaparib, whilst the mutation you have, the CHEK2, we just don't have the evidence. We have the evidence for the BRCA2, and CHEK2 is somewhat related to the BRCA. It's in the pathway. It's one of the mutations along the way that causes the BRCA2 to mutate. But we have not seen the PARP inhibitors have an impact for men who have CHEK2, but we do know it has an impact for the men that have BRCA2. Rex, I didn't explain that very well. Can you do a better job? No. Okay.
I don't think so. I've never been on any of these medications, and I just wanted to know why Carl was doing so well on his, and the BRCA2 explains that.
Yeah. Anyone else?
Yeah, I have two things. Number one, Carl, I'd be concerned about going back to the gym as soon as they open. You might want to wait a few weeks and see what the infection rate there is. And of course, hopefully when you do go, you'll be wearing a mask, which means it's kind of difficult to really give yourself a good, strong workout when you're wearing a mask. You might be better off walking the streets of central New Jersey. You have, is it flat there, or do you have hills that can challenge?
Yes, I've been getting somewhat bored with walking around. My development. There's about 400 homes in my active adult community, and the main street called Brookside Drive is a little less than a mile long, and I walk it at least 2 to 3 times on a daily basis. So that's my exercise.
The other thing is, if ever your PSA does start rising while you're on olaparib, just something to keep in the back of your mind to talk about with your oncologist. The reason that Professor Bill stopped responding was because his BRCA2, even though it was germline, his mutation reverted to wild type, meaning he no longer had the BRCA2 mutation at all.
Wow.
That's amazing. But obviously that was the end of the line for the PARP inhibitors for him. It just wasn't going to work anymore. Just something to keep in the back of your mind. Long time from now, we hope.
Right, and just to add for those who are not familiar with my entire story is that I did have immunotherapy back in March of 2019. I had the Provenge for a 5-week stint of infusions. So whether that's contributed, well, let's say it is. It has contributed overall.
Good point.
I just wanted to point out that PARP inhibitors also have some effect on people with ATM, to a lesser degree than BRCA2, but somewhat to ATM.
Yeah. ATM is is another one that's in the pathway, absolutely. And PALB is another one. There's a whole bunch, but I think there's been some observation of response with ATM in prostate cancer, but I know that with CHEK2 and PLB1, I think it is, there's not. So, all right, guys. Well, we're only 5 minutes over, even with all these people. I just want to say that put that, I think I mentioned it in the reminder, but make a note on the 30th of June. You're going to be seeing Carl and you're going to be seeing Peter and Carl's daughter and Peter's son, and you're going to see Alicia Morgans and a couple of other guys, and we're going to have a really interesting discussion on how you talk to your kids about your prostate cancer diagnosis and progression. And we're going to have a doc, a urologist from Cleveland Clinic, who's involved with the Mention It study, which is a men's health communications study. And Dr. Morgans is going to basically moderate. We're going to have a 10-minute presentation from Dr. Berglund from Cleveland Clinic, and then Dr. Morgans is going to moderate this discussion for 40 or 50 minutes, and she'll get into all the issues she thinks that are important around prostate cancer and your kids, and Carl's particular issue of having BRCA2. And I don't want to give away the game, but Carl has passed it on to his daughter, Shari. So it should be a really, really good discussion. And I will tell you, we've already got around 120 people or more signed up, and we haven't even started promoting yet. So this is going to be, this will be a really decent size event, and we're looking forward to it big time. So, all right, next meeting is on next Tuesday. That'll be the last meeting of this month. The talk, as we call it, is going to be on the 5th week of the month. So we're not taking away from any of these meetings. And we'll see you all next week. Stay cool.
Thanks, everybody.
Bye. Peace. Peace, peace, peace. Bye, everybody.
Thank you.
Night all.
Good night, good night.